Right. Now, this is just a disclosure because I picked up a number of photographs from a number of sources, including the net, and we have the SCNA and the Mangold Abdominal Operations, that 13th edition. I've just given a disclosure. So just with the preamble out here, so basically we talk about the colostomy or the ileostomy or any kind of ostomy for that matter. You all know it's basically a diversion of intestinal flow of contents, right? You divert the content, or less commonly for feeding purposes, like for example a jejunostomy or a gastrostomy. Now, basically, when you try to design an ostomy, it can either be temporary or it can be permanent. Okay, and more often than not, it's a life-saving service, right? Life-saving procedure, whatever the reason may be, as an emergency or an elective in a malignant patient. So basically, talking about a life-saving exercise. The fashioning has to be very, very meticulous. It's not just that you bring the bowel out and just forget about it. No, sir, you don't do that, because that creates a lot of problems for the patient and for you in the post-operative period and further down the line. Because the complications are many. And these complications are often morbid, and they're always morbid, of course, but they're often mortal also, right? And when you make a ostomy, preferably it has to be closed if it is a temporary ostomy. And the right time to close it could be somewhere around 3 to 6 weeks. Basically, it would also depend on the basic reason for which it has been made or constructed. And remember one thing, that it is a major psychological trauma. It's always a major psychological trauma. So basically, some points to reflect upon. Number one, colostomy. And if you look at the colostomy, the most ideal segment of the colon is the descending or the proximal sigmoid. The distal sigmoid is not a very good part to select for making colostomy. Why? Because it's a floppy segment, and there's an increased risk of prolapse with the distal segment of the sigmoid colon. So prefer, if you want to bring out the sigmoid, always prefer the proximal end of the sigmoid. Transverse is very commonly done, but it should not be done, basically because a number of problems with the transverse colostomy. But we still see that's the most commonly done colostomy, right? So the preference should be given a descending or the proximal sigmoid, right? If you're selecting the ileostomy, you want to do ileostomy, then you're basically selecting the distal segment of the small bowel, and you have to select a segment which can exit up to 5 centimeters of the abdominal wall. That basically means that whatever segment you're selecting, when you bring it out through the ileostomy opening in the abdominal wall that you made, the aperture you made in the abdomen, the bowel should be at least drawn 5 centimeters up. That's how loose it should be. If you're not able to do that, select another part of the bowel, right? So remember that. Descending colon, proximal sigmoid, or a segment of the small bowel which can be drawn up to 5 centimeters without any undue tension on the mesentery. And whenever you're doing this, you have to prevent ischemia of the bowel. For the colon, if you want to prevent the ischemia, you have resected and brought out the kindly close the mic, please. So in a colon, always ensure a functioning marginal arcade abdomen. We all know what the arcade abdomen is, so you have to have a functioning arterial arcade abdomen if it is present. It's not there in 100% of cases, of course. For ileum, always an intact arcade of ileal vessel should be preserved. You have to preserve that if you want your colostomy or the ileostomy to function correctly without any ischemic problem. Other less common sites apart from the ileostomy and colostomy could be a cecum. Often do that when you want to do a decompression of ascending colon and the cecum, or the appendix. Now, appendix is always not very commonly done. It's very rare that you bring the appendix out as appendicostomy, and that is usually done in the MACE operation, what's known as Malone's antegrade continent enema. Now, this is basically a procedure selected for chronic constipators. You have tried everything under the sun, and still the patient refuses to respond to his chronic constipation. So what you do is that you bring the opening of the appendix up to the abdominal wall near the umbilicus, and intermittently you just push in a tube and fill the edema. So that's basically antegrade, and that enema helps, and over a period of time the patient may be or may start responding. So this is basically a antegrade continent enema. Now, small bowel, we all know, apart from the ileum, the jejunum could be brought out for feeding purposes. You all know about that. Like, for example, a patient acute pancreatitis, or a patient who's got a gastric carcinoma of the pylorus. In these instances, you have to bring jejunum out as a feeding. Rarely, the jejunum should be brought or has to be brought out as a jejunostomy, especially in those patients who got a massive gangrene of the small bowel, except the proximal part of the jejunum, right? Like, for example, ischemic jejunitis, but vascular insult secondary to thrombosis or volvulus. So these are instances where the jejunostomy has to be brought out as a draining method rather than as a feeding jejunostomy, right? Then proximal bowel, the stomach and the duodenum can always be brought out to the exterior. You can do an ostomy in the stomach and duodenum, but we will skip that because basically we talk about the intestinal ostomies. We stick to the colostomies and the ileostomy and jejunostomy. So what are the indications for stoma? You can be doing a temporary diversion or you could be doing a permanent diversion, which could be more commonly a end ostomy. So if you're doing a temporary diversion, whether it's a small bowel or large bowel, prefer to do a loop. Why? Because closure of a loop is much easier than closure of the end. So you prefer doing a loop. Prophylactically, like for example, you want to protect distal anastomosis. Like for example, you've done a transverse colic anastomosis and you want to protect it, do ileostomy. So it is a protecting mechanism, or you can do an emergency proximal diversion after leaked distal anastomosis. You suspect that the anastomosis is leaked, you re-enter the abdomen and then you have to make a proximal. You repair it, of course, but then on the safe side, you make a proximal ostomy. Emergency decompression, like for example, large bowel obstruction, could be benign or malignant, like for example, gangrenous bowel or other vascular insults. It could be as a result of perineal injury, an abdominal injury. You may have to do temporary ostomies. Rectovaginal fistulas, the patient is not responding to a number of operations. You have to give rest to that part. So what you do is a ostomy. Or like for example, fecal incontinence, multiple perineal fistulas. So these are some of the, this whole list. I just picked up some of them, right? Now, the permanent ostomies, like for example, after APR or an inoperable rectal carcinoma, you do a Hartmann's operation, or a colonic cancer, you do a colectomy, or if you do a colectomy for ulcerative colitis, you make a continent ileostomy, right? Or after colectomy, like for example, in Crohn's disease, or you're making an ileal pouch for ureteric implant. So these are just some of the indications for making the stoma. So what are the types of stoma? It could either be permanent and temporary. I just now told you. So permanent, as I said earlier, usually prefer an end, or it can be loop, but prefer an end ostomy. Temporary, more commonly loop, could be end, like for example, Hartmann's. It could be a temporary or a permanent Hartmann's operation. We all know that. You do a sigmoid gangrene, you do a sigmoid, and you close the distal limb, you leave the proximal as go ahead and do an later point of time. Right? Construction method could be a continent ileostomy, or it could be an end or a loop, as just now said. The loop types could be a simple loop. It could be a barrel where you have two separate openings in the abdominal wall. You could have a defunctioning loop where there's a rim of skin in between, where the distal limb now acts as a mucous fistula, or you can have what's known as an end loop ileostomy, right? Now, technically important stages whenever you're constructing a stoma. Number one, the stoma has to sit on the abdominal wall at a optimal place. What do we mean optimal? Just talk about that. There should be adequate mobilization of the bowel. That's important. And at the same time, when you're mobilizing, be sure that you preserve the blood supply of this segment which is being drawn out. And the inversion of bowel wall during the stoma maturation, because you want to make a nipple, so the pouching would be much easier when you make a inverted part of the bowel. So what about stoma positioning? What's so particular? Why there's so much talk about stoma positioning? Now there are a number of points to be remembered whenever you're trying to position a stoma. Number one, it should preferably be in the outer third of the rectus muscle. Why? Because you want to prevent the peristomal hernia, and at least 2 inches from the midline. Point number one. So that now we know about the transverse extent. It should be in the lateral outer third of the rectus and at least 2 inches from the midline. What about the craniocaudal? Craniocaudal, it should be at the summit of the infraumbilical pad of fat. So it should be basically just infraumbilical. Just infraumbilical, the rectus, we all know that now, right? The ileostomy site thus have to be in the right lower quadrant, and colostomy site usually would be in the left lower quadrant. There's a whole lot of discrepancies. Suppose you still want to bring out the transverse colon. Obviously not going to bring it out in the left side of the abdomen. It has to be on the right side, right? Now, except in emergency situation, you should preferably always mark the stoma pre-operatively. Remember that. If you have to do an elective stoma formation, always mark the site pre-operatively. If you're doing it in emergency, you can't help it. It should always lie below the belt line in the patient's normal posture or in the standing position, right? Stoma should always be visible to the patient himself. Always remember this. Whenever you create a stoma, the patient should always be able to look at the stoma, right? It should be away from bony interferences like the endocephalic spine, the iliac crest, or the costal margin. Basically, you want unhampered pouch attachment, so it has to be away from the bony protuberance. It should be preferably never too much away from the mid-clavicular line. So if you are not able to do it at the rectus, you want to go more laterally, but should not go more lateral to the mid-clavicular line, because then you encounter above the costal margin and below the iliac. It should always be positioned over a healthy skin and a flat surface. And you have to make relevant allowances while considering a special group of patients, meaning what? Wheelchair patients with posture defects, like for example kyphosis, altered physical characteristics of the torso or the trunk. The patient is so huge, so obese that he has got a protuberant abdomen falling down, scars, hernia, or you have pendulous breast. So these are some of the situations where you have to be very careful about the positioning of this stone. So how do you do it? We all know it. You've been doing it right from a second year GRC. We all know that. But do you really know you're doing it the right method or not? You have to raise a part of the skin and remove a disc of 2.5 centimeters in diameter. Remember, please do not remove the subcutaneous tissue. Core it out. Don't remove it. Right? Why? Because the moment you remove the subcutaneous tissue, the support of the bowel which has been brought out is gone. Right? So you just retract the subcutaneous tissue. Some of them, or some would like to do instead of the skin disc, they would like to make a cruciate incision over the skin, but that should not be a very good option. That would not be a very good option. So you're trying to retract subcutaneous tissue, and you retract it until the anterior rectus wall sheath is in front of you. Right? So when you have that sheath in front of you, either make a vertical incision or you make a cruciate incision. Vertical about 3 centimeters or a cruciate incision over that particular part, and the cruciate should be such that the lateral limb of the cruciate should be larger and should be extending at least 2 inches away from the midline. Right? So the 3 centimeter or the cruciate should be at least 2 inches away from the midline. It should not be encroaching on the midline. Right? At the midpoint of the incision, you make a perpendicular to that a 1 centimeter incision laterally. If you are given a vertical, you make a 1 centimeter incision laterally. Why? You don't want to extend it medially, so make it laterally. If you give a cruciate, then the part of the cruciate should be more lateral extended. Right? Now, that basically is ensuring what? You don't want the stomal opening to be going to the midline. Now, what do? You cut the muscles? No. You just split the rectus abdominis muscle in the direction of its fiber. Just split it. Now, what do? You have in front of you the posterior rectus sheath. Those of you who have done a TP being done, you see that how it is done. When you retract you retract the whole rectus laterally. But here splitting it and retracting the medially and laterally until you have the posterior rectus sheath in front of you. Once you have that, now give a vertical incision. How large? Remember this, 2 finger breadth exit opening. Remember this. This is very important. Why? Because this is a dimension which would work both for the colon and for the eye. Right? Why? You would imagine that the 2 finger breadth would hardly be accommodating the colon for you. No, it would. It would. The moment you have a larger opening, the chance of having a parastomal hernia, they jump up. Okay? They increase. So basically looking at 2 finger breadth exit opening. Now the relevant bowel is drawn out of the right anatomical orientation that has to be maintained. You have to maintain the right anatomical orientation, and the drawing out has to be either with a tape, bring it out, or a Babcock. You feel that there is some tension on this, please do not give excessive strength on the Babcock. You're going to tear the bowel. You all know that, right? Now, there should be no compromise on vascularity. That is very important. Now, eversion of the bowel end as a nipple can only be done if the colostomy which has been drawn out is at least 2 centimeters above the skin surface, right? If you bring the colostomy out at least 2 centimeters, only then you can have a matured colostomy protrusion of 0.5 to 1 centimeter. If you can't bring it out 2 centimeters, you can never have an eversion of 0.5 to 1 centimeter. Similarly, for ileostomy, you have to bring it out at least 5 centimeters. Only then you can have an eversion of 2 to 2.5 centimeters, right? So that is very important. Now, what are you doing now? Now, always ensure that the facial opening is adequately sized. We said 2 finger breadth, but there may be an indication or there may be an instance where that may be too tight. How do you know it's too tight? You insert a finger between the bowel and the facial aperture. Now, if your finger can roll between the bowel and the opening, it is not too tight, right? So remember that. It cannot be too tight. So you just insert your finger and roll it around the bowel in the aperture. Okay? Now, transversely incise the anti-mesenteric border of the distal side of the loop. Right? Distal side of the loop. See, the distal side. It's not in the middle. It's not in the middle. It's the distal side of the loop. Why? Because you want to make the proximal part of the colostomy loop or the ostomy loop larger than the distal part. Why? Because you want an inverted proximal and a flush distal. Flush basically means what? Flush with the skin surface. And the division should be at least more than half of the bowel circumference, right? So distal side of the loop and more than half the bowel circumference, so that the functioning proximal limb and non-functioning, they are separated. Because see, if this is the loop, you can make it here at the most prominent point, or you make it here. Now, if you make it here, when you make a nipple, it will go here, and this will become flush. So they are easily separated even with a loop. You don't really require deep functioning. So here basically it is a loop which is corrected. If you correctly make it, then it would not allow too much to go into the distal. So eversion of the proximal limb, it should be done, and the distal limb can be left at skin level. I'll just show you in one of the figures what you basically do. Now, how do you stitch it? One, you have to give stitches to seromuscular stitches to the peritoneum, number 1. Number 2, seromuscular stitches with the muscle layer, and then what you require is 3-point suturing with the skin edge so that it gives a eversion of the edges. 3-point suturing basically is what? Skin, seromuscular, and edge of the colostomy. When you tighten it, you'll get a nipple like this. So that is basically what you're looking at. Now, when you're doing this, one thing else I've written here basically is a retromuscular polypropylene mesh we put as a keyhole, so a baker sandwich. We'll talk about what this basically means. But just remember that at this point of time, you can insert or you can put in a mesh, right? A retromuscular mesh, meaning what? In between the rectus and the posterior sheath. Okay? Now, if you put a mesh there, you are preventing one important, or you may be preventing one important complication in the postoperative period, and that is a parastomal hernia. Now, we just talk about that in one of the later slides, right? So, this could be done at this very point of time. Now, when you're fashioning the stoma, you have to be particular about what? Number 1, an adequate mobilization has to be there to obviate tension. We have been repeatedly saying that because that's a very common mistake done. And what we find in the postoperative wards is that the mesh, the whole of the bowel has gone in or receded inside the abdomen, or you can't see the inverted bowel at all, right? The mesentery should be fixed, and fixation in such a way that you do not damage the vascularity, right? Now, if we just now talked about the prophylactic mesh. Now, you have a choice between a biological mesh or you have a choice between polypropylene. Now, what is important? Important is the cost factor, and important is the complication. Now, initially it was believed that putting in a polypropylene mesh is going to create a problem in the form of increased infection. It is a non-absorbable mesh. So, we have been taught that non-absorbable mesh, once gets infected, the infection will not go. Biological mesh was always preferred for that scenario. But they did a lot of trials, and this was the largest trial, the PREVENT trial, where the final results are still pending. But they showed that there is no increased rate of infection or stricture in a multi-centric randomized controlled trial as compared to biological mesh, when what you're comparing is basically the polypropylene. Okay? And 13 multiple randomized controlled trials also say the same thing. The results did vary, but probably an advantage of parastomal hernias prevention with prophylactic mesh placement. Polypropylene and biological mesh, if you look at the cost factor, hugely different. But there could be another thing. You don't want to put an mesh, you don't want to put an mesh at all. What can you do? You can bring the bowel out to the colostomy side or the ostomy side, whatever it is, to an extra peritoneal route. That is one of the best methods, and that is one of the methods always be advised in APR. The descending colon is always preferably brought out to the site of ostomy through an extra peritoneal route, right? So that is one of the better methods of doing or preventing parastomal hernia formation. Now, very good. Everything is very good, but there are scenarios when this kind of a problem does not, or this kind of a scenario does not happen in every patient. You have a number of problematic scenarios. Let's examine one. Scenario number one, you got a very short mesentery, where the patient is obese, or even otherwise, there's a short and thick mesentery, thick abdominal wall. Now what do you do? You're trying to drag the descending colon out, you're trying to drag the transverse colon out, and you're trying to drag the small bowel out, and you find what you find that it's not easily done. The moment you try to apply some pressure over it, what's going to happen? The mesentery is going to tear, or the bowel is going to come out in your hand. So adequate mobilization in these patients is not easy. You have to adequately mobilize. It is not coming to the abdominal wall, but it has to do some kind of a stoma. That is essential that this patient has a stoma. I am not able to bring it out. So what do you do? What do I do? Number one, mesenteric mobilization. Now, when you talk about the small bowel mesenteric lengthening, you basically are lengthening it with the thinning of the vascular arcade without devascularization. Let me show you this figure. See, this is basically the small bowel, right? You can see the small bowel out here. And what has been done? You have gone through the mesentery. What have you preserved? You're preserving the arcade. If you're preserving the arcade, see, the blood is going to come from here, is going to supply the blood vessel. If you're going to cut through here, trying to cut the mesentery out here, what's going to happen? None of the arcades are there. So always preserve the distalmost arcade and the starting point of the arcade when you're trying to mobilize a small bowel mesentery. So this is how you do a mobilization of small bowel mesentery. And now you got enough length. Now you have enough length. You can bring it out 5 centimeters, 10 centimeters, whatever, right? Now, when you're talking about the large bowel, so that is done. Some small bowel mesenteric lengthening has been done. Now you basically want to lengthen a colonic mobilization or colonic mesentery. Why? Because the colonic mesentery, whether the descending colon, which is the preferred or sigmoid, for some reason is not being drawn out adequately to the ostomy side. Now what do? There you have to, number one, the lateral attachments have been mobilized. Agreed, no problem. But even with that mobilization, often you would have seen that the bowel end cannot be brought to the ostomy side. Now what do? Now there basically, as is done in a low anterior section, LAR, you have to transect a few vessels. And these are basically the inferior mesenteric artery and the inferior mesenteric vein. So these have to be resected, or not resected, they have to cut or transected, right? So sorry, I used that word resected, transected. Now see, this is basically the descending colon. What do you have here? The inferior mesenteric artery. You got the left colic artery out here, and you got the sigmoid vessels out. Now either you can do a transection here, or you can do a transection here once the left colic has already exited from the inferior mesenteric. If you're doing a transection here, this would be known as a low ligation of the inferior mesenteric artery. Why? Because this transection has been done. That means you tie, ligate and transect below the origin of the left colic artery. This is the left colic artery. See, ascending and descending branches. Left colic. This is sigmoid 1 and sigmoid 2. There were 3 or 4 sigmoid vessels. Right? So I am basically tying here because I don't want the vessels to this particular area to be severe. This patient will not have any kind of vascularity compromise if I am tying it out here. There may be an indication where you may have to ligate it here. But if you're going to ligate out here, just be sure about one thing, and that is the arterial arcade of Drummond is always there. Drummond is always there. If you don't have an arterial arcade of Drummond, for God's sake, never do a high ligation of a inferior mesenteric artery. Don't do it, right? So if the arterial artery Drummond is very much there, it's not there 100% of the time, remember that. But if it is there, then you can afford to do a high ligation of inferior mesenteric artery. Not there, you have to do a low ligation where you spare the left colic artery. Now, once you have done this, even then, you're not able to mobilize this colon. Why? What is holding it back? These veins are holding it back. So what do? I basically transect this vein, which is the inferior mesenteric vein. And where do I transect it? See, inferior mesenteric splenic vein, taking the portal vein. We all know our anatomy. Where do I transect it? Now, behind here, something is lying. What lies out here? The pancreas. So, where do I dissect it? I go up to the lower border of the pancreas, and that is where I ligate and transect the inferior mesenteric vein. So, remember this. Now, you would basically be wondering how I'm going to do all this. Do I do a complete mobilization and then put everything medially? No, I don't do that. We never do that. Now, what is advice is that you go through the mesentery. Basically, this is known as medial to lateral mobilization mesentery. Medial to lateral. So, I am cutting here and then mobilizing. So, I have to go to the mesentery. You can also do it by reflecting everything medially. But then that would be mobilization right from here. Remember, you have to mobilize from here the splenic flexure. You have to mobilize the lateral third of the transverse colon, the whole of the descending and parasigmoid. Push everything medially, and then only you can approach these ones. Else, what you can do is basically you can go through the mesentery, and it is always better to approach the inferior mesenteric vein through the transverse colon mesentery. You can easily see that because the colon, the pancreas lying where? Just above the transverse mesocolon, right? So you can easily enter that plane through the. So remember, ligation of the inferior mesenteric artery either high, low, and ligation of the inferior mesenteric. This is basically the same thing, inferior mesenteric vein, and I ligate the left colonic vein and the left colic artery, right? That is basically the high ligation. If I just ligate these two out here, see where the ligation being done is done beyond the left, right? That is basically the low ligation of the inferior mesenteric vein. So even the inferior mesenteric vein would be having a high and low ligation. So if you're doing a ligation at the lower border of the pancreas, you'll be doing a high ligation of the inferior mesenteric vein. While, see, this is the left colic. Can you see this left colic vein? So if I'm doing a ligation here, then it would be a low ligation of the inferior mesenteric vein. So remember, both vein and artery can be subjected to a high ligation and a low ligation. Okay, this we already talked about. Now, scenario number 2. So I have been able to mobilize the colostomy, and I easily bring the bowel onto the abdominal wall. Everything we do, but there could be a problem, and that is always there in highly obese persons. See, stoma creation in an obese patient 7 times more likely to suffer from stoma necrosis than non-obese persons. And why? The main problem is enough mobilization not there, right? So in these patients, there are certain other problems also. Number 1, position of stoma in the upper part of the abdomen is the thinnest part of the abdominal wall. So always try to position the stoma not in the infraumbilical area, but now I'd like to position it somewhere in the higher part. Why? Because I want to have a thin abdominal wall. The abdominal wall thickness making the problem, it's creating a problem. So what do I want? I basically want it to be lying slightly higher. Okay, so position in the upper part of the abdomen. Number 1. If still you find the abdominal wall is very thick, then what you can do is you can excise excessive subcutaneous fat, what is known as subcutaneous lipectomy. Now what do I have? I have the skin and I have only muscle in between. The subcutaneous tissue has been removed. So I fix the skin to the. I've got a very thin ring, which I can easily bring the whole thing out. Create ostomy. Why? Because the whole subcutaneous tissue is the major impediment I can do. Or what else I can do is I can move on the thing along with the subcutaneous. I can do both things, right? So basically, everything is aimed at what? Trying to decrease the wall. But in doing that, you have to remember one thing, that you are creating a scenario where there will be increasing chance of stomal hurt. right? Number two, in a patient who is obese, the other thing which is important is when the patient stands up, the whole of the abdomen falls down. So the stoma may be falling down with the standing of the patient. So you have to be very careful when you're positioning the stoma, right? With a heavy abdominal wall. Number two, if the patient loses weight in the post-operative period, again the stoma is going to be drawn caudal. If the stoma was cited capillary to a skin fold, future weight changes basically do not create a problem. But if it is around the umbilicus or below, remember the whole of it would be dragged down. And what you do is an instance. What you do is you have to do an extensive excision of the skin along with the surface to what is known as paniculectomy. So you have to do a paniculectomy in such instances where you find that the stoma you had created in an obese person, because of loss of weight of that patient, it is now drawn more forward, right? In patients who have got a small abdominal wall deformities, which are impairing the pouching, what you can do is to decrease the amount of subcutaneous tissue, you can fibrose it. By what? By parastomal porcine collagen injections, which basically promote fibrosis, and that could be an alternative of doing a paniculectomy, right? So either inject or you do a paniculectomy. Scenario number three, the bowel is so friable and the mesentery is so short that the moment I try to apply Babcock and try to drag it down, everything bursts open. So I'm going to have a ruptured bowel. Okay? So in these cases, you can follow one of the Jones technique where several additional centimeter bowel is exteriorized and wrapped with gauze and then matured to 5 to 7 days. This is only for friable. But if you have friability along with shortness, then you only have two options available. Number one, incision line stoma, that you just create a stoma in the incision line. And number two, you have a large drain in the loop. You can just, the loop has not been drawn out, so you just put in a tube and you fix the tube inside the abdomen to the loop of the intestine, and you fix the tube to the abdominal wall, and that's the end of it. But that's not the end of it. It creates so many complications that you would be in dire straits. In addition to this, what or other things can be done in any scenario where the mesentery is short and dragging it out becomes difficult, you can do another loop and ostomy, because this gives the increased reach and decreases chance of devascularization of the stoma. The anteromesenteric portion of the bowel should be matured to the skin, and a drain is left in the distal staple line to prevent the flow. I'll just show you what this is. Right. So these are ostomies. See this. This is the nipples which have been drawn out. Now this is basically the loop. See, the proximal limb has been drawn up, and this is flush with the skin. So whatever is coming out would enter this part hardly any. So this is basically a typical loop, and that's how it looks, where you have not drawn a nipple out. So this would be just a simple loop here. Part of it is going to the distal and part of it into the back. So this is basically a type of loop where the distal limb is not being bereft of fecal matter. It will always be entering into the distal limb. Remember that. The loop end I just talked about is basically you have drawn a loop and one part of the loop ends. That's why it's known as loop end colostomy. See this end? Now, this is basically we're talking about the proximal to distal. We are cutting where? Distal. How much circumference? More than half. And what do I do with this? I basically invert it, so I would have a scenario like this. Why? This is flush with the skin. This eversion will give rise to a nipple. So this basically will give you that, and this would be a stomal rod which prevents the abnormal regression or retraction of the loop into the abdomen, right? So this is basically what we're talking about. This becomes a mucous fistula, and this becomes the functioning. Okay, that's how it looks like. So loop stoma, end stoma, and two stomas, which is known as a barrel kind of a ostomy. Now, in difficult scenarios, ostomies, scenario number 3, hugely distended friable bowel with short mesentery, and you basically looking at a patient who has a toxic megacolon or Hirschsprung disease or has been a ulcerative colitis patient. Now, in these scenarios, what do you find? You create an opening just to do a colostomy or ileostomy, whichever is indicated that particular patient, and you find that the whole of the large bowel is filling the incision line that you've done. And you try to drag it down, what you find is so distended like a balloon, and you can't even hold it. The chances are very much there that your gripping is going to tear it out. The patient is already very sick. He's a very sick patient. And because he's a sick patient, you're going to increase the septicemia. You don't have too much time to operate. The anesthetic is at your back. Do whatever you want as early as possible. Minimal surgery. So what do you do in these cases? What you do in these cases is basically localize this part of the bowel by ultrasound. Now you know where the large bowel is lying or the distended bowel is lying. Identify a tinea coli. Identify tinea coli, right? Now, fixation segment is required. Why? If you make an opening and you're not fixing the bowel to the abdominal wall, what's going to happen? It's going to leak into the peritoneal cavity and is going to give rise to a leakage. So, you first of all select a possible site of colostomy, a future site of colostomy. Now, once you've done that, don't make it. Don't make an opening in the bowel yet. What do? Now you select a part of the large bowel which would be fixed with neuromuscular sutures to the abdominal wall. Right? Now, how do you select this distance? This distance from the proposed colostomy site to the end of the wound should be a distance which should be equal or more than the thickness of the blood of the abdominal wall. Why? You may say why? Because see, what are you going to do? This part is going to be approximated here. That basically means this whole thing would be lying against the abdominal wall. So, point 1, point 2, point 3. The first layer of sutures to the peritoneum, second to the muscle, and third to the skin. Right? So, that means this length of the bowel should be there with you. Would only be there if the side of the colostomy is at equidistant to this length from the wall. That means this distance and this distance should be equal. So, you're creating 3 layers of sutures, seromuscular with peritoneum and the wall, seromuscular with the muscle, and then full thickness with the skin. Right? Now, this full thickness, the rest 2 are seromuscular. This is basically a different colostomy and scenario 3, and this kind has been mentioned in books as a blowout colostomy, in some books as a blowout colostomy. I wasn't very familiar with this name. I don't know why they named it blowout colostomy. But remember that when you're doing it, that's one more thing. The first thing, so once you have applied this layer of suture, now what do? Now you put in a thick bore needle, either 18 gauge or a thicker needle, right? Now what happens? Once you aspirate the gas, what happens? The whole thing collapses. Now you make an opening and then you push a suction tube inside. And you suction whatever you want. Now, the second layer would be somewhere here, and this you will apply to the muscle layer. And then you go the margin, and this margin you're going to apply to the skin, right? So this is basically the situation scenario number 3. Now, I said earlier, you have done a mesenteric mobilization. Now you decide on the adequacy of bowel and vascularity. Close your mic. Somebody with the mic on. Please close your mic. So, deciding the adequacy of bowel and vascularity, how to do that? Open surgery, it is easy. It's easy. How? You can see the capillary ooze from the edges. You can see the mesenteric pulsations. You can see the arcade retirement if you're doing a colostomy. You can apply a bulldog clamp for temporary occlusion. You can find the ends undergoing color change. You remove the bulldog. So it's very easy. But what happens in lab surgery? Doing a lab ostomy, what do? One visual inspection could be there. You're inspecting the bleeding, the oozing. But the second thing, which is perhaps more important and which could be more confirmatory, would be a near infrared iodocyanogreen fluorescence imaging. This is basically if you have been fortunate enough to go on one of the workshops, to go one of these laparoscopic workshops where they now try to delineate the common bile duct. It is being delineated with the same principle. They use NIR ICG fluorescence. This is basically near infrared because that is being emitted. That is the spectrum where this starts emitting fluorescence, right? The iodocyanogreen. So this starts emitting fluorescence in NIR spectrum. That's why it's known as NIR ICG. And the telescope has to be a different kind of telescope. It has to be adaptable to fluorescence and to normal light. So they are different telescopes, right? And what do you find? You find a greenish fluorescence in a patient having a normal bowel circulation within 1 minute, 57 seconds. right? So you've injected this into mesentery, and you find within a minute, you find a green fluorescence at the end of the bowel that you have resected, which you now want to bring out as a ostomy, right? So that's very important. So this is the laparoscopic method of deciding or of the adequacy of bowel and vascularity. The other methods are preoperative methods. You're doing a trans-abdominal Doppler ultrasound, a transabdominal laser Doppler, fluorometry, or oxygen spectroscopy. So these are other methods. This is a special type of ileostomy. You all are familiar with this. This is basically continent, and this was a COP continent ileostomy, and this is basically usually done in terminal ileostomies, done for complete colectomies, where you want to have a continent ileostomy where you don't keep on the waste doesn't keep on coming into a pouch. Here, basically, when you put in a catheter, you can easily make this functional and you remove the catheter. Let's not go into the details how it's made. Just show you a figure. So, what happens when you create an ostomy? It's ileostomy. Colostomy not too problematic. Why? Because by the time the intestinal contents have reached the distal part of the colon, it's already everything has been absorbed, including water. So that is basically particularly waste. So no problems there. But if you're doing or you're making an ileostomy, then that has some problem, and that's got physiological maturation of an ileostomy stone. The physiological maturation as opposed to anatomical maturation, where you invert the mucosa and attach to the skin, that is anatomical maturation. This is physiological maturation. So in most of the cases of ileostomy, in elective or in emergency, most of these basically they've got 3 periods of adaptation. Up to 3 to 4 days, you'll find that the output increases maybe even up to more than 1 liter per day. And you're worried, why do I have 1 liter a day in this pouch? The next 4 to 6 days are basically the periods of stabilization. Now it's going to be stabilized to about 500 milliliters per day. That's about half a liter per day. And subsequent to 6 days, that may end of first week and up to a period of extending up to 6 weeks or more, you're basically going to have what? Gradually decreasing and thickening. Both are there. The amount decreases and becomes thickened. So thickening and decrease amount to almost in the region of around 100 to 200 ml per day. That is basically what you're hoping for. That's what you're hoping for. But if you find that the volume persists even after a week in the region of about 500 ml per day, then there is a problem somewhere. And that problem could be a disease in the bowel, either distal or proximal. You're basically either having a inflammatory bowel disease, enteritis for some other reason, distal obstruction, or a shortcut syndrome, right? So any of these conditions, you're basically having a persistence of volume outflow or effluent outflow of more than 500 ml. Now, what is happening in this physiological maturation? During the period of physiological maturation, the first 2 weeks, you have the maximum chances of having some kind of fluid and electrolyte abnormality. Subsequent to 2 weeks, you basically do not have this kind of abnormality. It's only the first 2 weeks where you have to be very, very careful about fluid and electrolyte abnormality. So dehydration and metabolic pouching problems are there. That means the pouch that you fit onto that particular area, the liquid effluent is there, so it keeps on leaking. If the pouch is not well fitted, because the pouch cannot be fitted onto that particular side. Why? Because you didn't make an optimal stomal site. So if the stoma site is optimal, the pouch fitting should not be a problem. But the huge amount of fluent could be a problem. And then, of course, the effluent leaks and the huge volume, right? So basically, we look at the metabolic effect. One, of course, we said huge volume. But what metabolically is happening there? Number one, the electrolyte abnormalities in the form of low sodium, potassium, and magnesium. Patient is losing all these things. Why is he losing sodium? He's losing sodium because the effluent which is coming out has a sodium content of almost 60 milligrams per day. Compare it with the sodium content of the stool, you'll find it's almost 2 to 3 times more that loss in the stool, right? So if you have a loss of almost 2 to 3 times of the content loss in stool, you'll be having a major amount of sodium loss. And what does the body do? The body tries to conserve. By what? By the renal conservation of sodium and water. Very good. We all know that. But despite this retention and the renal conservation, you find what? You still find hyponatremia in these patients. So that means the renal compensation is not enough for these patients, right? Now, this hyponatremia, apart from the fact it's got low sodium, it also leads to what? Hyperaldosteronism. That's what is responsible for the sodium absorption in the convoluted loop. We all know that. But the hyperaldosteronism has some other effects also, and that is, apart from the fact it tries to retain sodium, it has to lose what? Potassium and magnesium. It's as simple as that. We all know that from our knowledge of physiology of this convoluted loop. Cations exchange for cations, anion for anion. So if you're going to retain sodium, you have to lose something. And what do you have to lose? You've got hydrogen, you've got potassium, you've got magnesium. So these two also become less in amount than the normal. So you have low sodium, low potassium, excessive loss in distal convoluted tubule. The hypomagnesium, yes, distal convoluted. But apart from that, it is also by the chelation of this iron with what? Unabsorbed fatty acids in the bowel, which are not absorbed. Why? Because these acids would be maximally absorbed in the terminal part of the bowel. It's not being absorbed. So what is happening? It is going to chelate the magnesium. So magnesium is lost by two methods. Number one, the increased aldosterone by the exchange for sodium in the convoluted tubule, and number two, by chelation with the fatty acid. If by chance the terminal 50 to 100 centimeters of ileum has been excised, in that case you'll be having major fat absorption, malabsorption, and that malabsorption is going to lead to malabsorption of fat-soluble vitamins. The problem with these vitamins, terminal ileum, we all know, is a major site for vitamin B12 absorption, so macrocytic anemia. Chronic dehydration, acidic urine. Why? Because that is the part from where the water is now being absorbed, right? So that is not being absorbed. So what has happened now? Increased chances of renal stone formation. Increased acidic urine, chronic dehydration, you have increased chances of renal stone. So this is basically, in a nutshell, what is happening metabolically out there, right? Now, you made an ostomy, you're very happy, everything is hunky-dory, but no. The patient comes back to you with what? Complication number one, which is perhaps one of the common complications, not very uncommon, is a parastomal hernia. We look at the epidemiology of the parastomal hernia and find that clinically symptomatic is a very widely quoted figure, as high as 39%, and for loop ileostomy 6%. That basically means there's a major concern in colostomy. Okay, now if you look at the recurrence after doing a mesh repair, the recurrence is almost 17%. Okay, now by CT, if you do an analysis of diagnosis of parastomal hernia patients, you'll find it as high as 78%. See the figure, clinical, and this is basically the diagnostic. So it's almost two times. Compared to 6%, much higher than that. But out of these, whosoever has either clinically diagnosed or investigatory diagnosed parastomal hernia, 1/3 of these would be requiring some kind of surgical repair. That means 2/3 can go on with conservative kind of therapy. Only 1/3 will be requiring surgery. And why would they be requiring surgery? Number one, either pain, incarceration of the hernia, obstruction, and another one is a poor pouching, a poor appliance fitting. All these reasons are enough to indicate that a surgery is required. So what are the risk factors? How can I prevent it? Number one, I have to understand what the patient-related factors are. Number one, probably higher in female gender, probably higher above 60 years, obesity, where the waist circumference is more than 100 centimeters, poor nutritional status, patient is hypertensive, he's got chronic airway disease. Why? Because in these instances, there's an increase in the intra-abdominal pressure, patient is depressed, immunity, and on steroids. So all these basically patient-related factors are all those which give rise to either increased IAP or a lax abdominal wall, right? Technical cause could be there. I do ostomy in an emergency patient. I do an ostomy in an elective patient. It's very obvious. In an emergency patient, there are a lot of problems. So emergency stoma construction is always logically going to be at increased risk for parastomal hernia. The rates in end stomas always more than loop stoma. In colostomies, always more than ileostomy. Remember that. And more than loop, colostomy more than ileostomy, right? Now, 2 finger breadth facial openings are just enough to accommodate the bowel without causing stricture ischias. See, the 2 finger breadth facial opening again comes out. So basically, you have to have a 2 finger breadth. Now, the moment I go above 2 finger breadth or an adequate size with every 1 millimeter extra size, I have a 10% increase in the incidence. So that's how problematic this is. Okay, the signs symptoms are very easy. We all know signs symptoms of hernia, complicated and uncomplicated. There is no problem with that. One additional problem in this patient would be problems with pouching. Why? Because the moment you apply the pouch, everything bulges out, the pouch gets dislodged. The problem with pouching is always there. It's a large parastomal hernia. The diagnosis is not very difficult except in a very, very fat person. In a very fat person, the diagnosis becomes difficult. Why? Because there you can't appreciate clinically the sac. So you can do a Valsalva clinical examination. You may be able to see the sac or feel the sac, but failing to do so, you're still suspecting PSH, you can go in for a CECT examination where you want to put in a radioactive or you want to put in a contrast dye, not radioactive, sorry, a contrast dye into the intestine and can easily delineate the intestine lying in a sac above the abdominal wall. So that is an important adjunct to a diagnosis of PSH, right? Conservative treatment is there. I told you 2/3 of the patient will respond to conservative therapy. What do you do in these patients? Reassure them. Make them wear abdominal belt. But the problem with abdominal belt is such that these patients, abdominal belt would be problematic because there is a ostomy there. Restriction of heavy work can easily be done. Surgically, I said earlier, 1/3 would be required. It can either be an emergency surgical intervention or it could be a now, out of all these 1/3 patients, half of them would be requiring emergency intervention, half of them would be requiring the elective. And that elective is again, we all talked about the poor appliance fitting, difficult evacuation, and cosmesis, which can also be noted down as sign symptoms. Difficult evacuation is again a problem because the whole of the bowel is lying there, compressing it. So difficult evacuation from the ostomy side is always there. The surgical options which are there, the easiest would be that, look, this is large, let me go and apply 2 or 3 sutures. What's happening in that case? Abandon. Don't do it. Why? Recurrence rate of 46 to 100%. That means just closing the facial defect per ostomally. That means you just open the skin and you find that opening there and you just try to apply 2 or 3 sutures. What's going to happen? It has to recur almost 100% of the time. So don't do it. Okay. Now, other methods could be either as a laparoscopic or open. Either of the two methods. You can do a stoma relocation. That basically means what? Close that opening, close that stoma, make a fresh stoma. But there is another problem with that. The recurrence rates are less than primary suturing, but still significant enough. And often laparotomy is required. So this is not a very good option, but an option which can be tried. Number 2, you can convert a intraperitoneal bowel into extraperitoneal drawn out ostomy. You can do it. Convert intraperitoneal drawn ostomy into extraperitoneal drawn ostomy. But what is now being advised, the procedure choice is for parastomal hernias is a mesh repair. So that's the gold standard. Now you go in for a mesh repair. Now where do you want to put the mesh? Either I can put it on top over the rectus or the external oblique, wherever the stoma is coming out from, not to be preferred. Why? The recurrence almost 26%. Mesh overlap 3 to 4 cm not easily possible. Mesh complications are very much there. And against the tenets of Tosca's law, we already talked about them, we talked about the ventilator. That's against the law. Sublay, pre-peritoneal may be difficult. Why? Because associated fibrosis may be there in that particular plane. So what remains? One, I put it inside the abdomen as an IPOM, or I put it as a sublay, which is subrectus, which is now perhaps one of the preferred methods of putting in a mesh. That means in between the rectus abdominis posterior wall, the posterior surface rectus abdominis, and the posterior sheath. In between that, that is behind the rectus. So behind the rectus would be a sublay, subrectus, and an IPOM. Right? Now putting in an IPOM, I've got a number of methods. I will just tell you what these are. What is the choice of mesh? I already talked about that. The polypropylene biological. See the recurrence rate with biological mesh, 15.7. Complication 26.2. Similar to that of synthetic mesh. So if you got a pretty cheap something, which is giving rise to the same results, or even better results as far as the recurrence rate is concerned, to something which is very costly, why don't you select it? So that is the scenario out here. Polypropylene is now become the mesh of choice for a prophylactic and therapeutic parastomal hernia repair. Is that clear? Now, what are surgical options? 3 options. The keyhole and the modified Sugar-Baker technique. The sandwich technique is another cumbersome technique. I'll just mention it because that is within the text. The keyhole is basically what? You just make a hole in the mesh. Simple. Make a hole in the mesh, you thread the bowel through the mesh and fix the mesh to the stoma side. It's as simple as that. That means the mesh is now being drawn out, the bowel is now being drawn out of the mesh, opening in the mesh, which is exactly resembling the hole or the facial defect in the abdominal wall. That is a keyhole, right? Now, gradual widening could be there. Over a particular period of time, the gradual widening is going to be there. Why? Because slit and create an opening, right? So that is going to create a problem. So recurrence rates to the tune of 20.8% and morbidity 17.2%, which includes wound infection and mesh infection. That is why the preferred method right now is probably a modified Stover-Baker technique where the bowel exists at the lateral border of the mesh. The recurrence rate laparoscopically is half of that, almost half of that with a keyhole. And sandwich is basically a combination of keyhole and modified Stover-Baker. Let's see what these are all about. Let's see this. Now see, this is basically a keyhole. See the skin, let's say sheath, the muscle, the peritoneum. So what is happening? This is one single hole and this is the mesh. One single hole. Everything is drawn out from here. So this is a slit in the mesh and it is now enclosing this, the hole, and the bowel is coming out. So the bowel is coming from here to here. One straight track. What happens in one straight track? Always problems of recurrence. That is what is happening out here. See this? Can you see this? This is the mesh and is being drawn out to the colostomy side. That is problematic. So what can I do? What else I can do is I can fix a mesh such that the bowel can go like this. Can you see this bowel? See this diagrammatically. Now what is happening? Bowel reaches the abdominal wall, then takes a short course and then comes out. So tunneling out here. There's the tunneling. And what makes the tunnel? The mesh makes the tunnel. So I am inserting the mesh such that the bowel is exiting from the lateral part of the mesh. Okay, from the lateral of the mesh. So it's entering the lateral of the mesh, following the abdominal wall intraperitoneally, and here is the opening. Here is the opening. So enters here and the opening. So this would be a preferred method. Why? Because here the hernia recurrence is less than this. Here it's a straight track. Here it's a curved track, or rather a angulated track. So that is a problem. See here, this is the opening, and you can see the bowel coming from here and going here, right? So this is basically a Stover-Baker, and that is a keyhole. Now we talk about what is the patch technique. Look at the patch technique. See what's being done in the patch technique. So the first mesh is like this. Same thing, no problem. Now over this mesh, now I apply a second mesh, which will be like a Stover-Baker technique. So the first mesh is a split mesh, and the second mesh is a non-split mesh, which is going to bring the bowel by angulation. So this is nothing but a dual repair, and that would be cumbersome. Just to a Stover-Baker technique, that would basically be helping. The sandwich, remember, keyhole plus Stover-Baker is the sandwich technique for modified repair. This is again a similar. This is the first mesh. You see this mesh? So basically split, and now over top of that, now apply. So you see the mesh going here. Now see this mesh. This time blurred out. Why? It's entering from the lateral edge. See this? Very nicely seen out here. Very nicely seen out here, right? So this is basically the second mesh, which is now angulating the mesh, and that's how it's coming. Okay. So can you prevent it? Yes, you already said. Always limit the size facial defect to 2 fingers. Always pick up a transrectus route. Go through the sheath, lateral end of the rectus sheath. Okay. An extraperitoneal course if possible. And then if nothing is possible, you have to come out of the rectus, lateral of the rectus, then go ahead and do a prophylactic mesh, probably a polypropylene, and by any of these methods. And if you put in a mesh, see the difference of recurrence. Without mesh, 53%, 12.5 with a mesh. That is basically the difference. Now coming to the second, and that is a PSH with prolapse. Now this is basically a prolapse. Can you see the bowel bulging out? Can you see the whole bulge? Now this is the umbilicus. Can you see the umbilicus out here? This hole is a bulge. And this was a bulge where the ostomy was made, and now everything is bulging out. So this patient got a prolapse along with a PSH. Okay. Now what does the stomal prolapse basically mean? The whole of the full thing of the bowel is now coming out from the ostomy side. The incidence, basically ileostomy 3%, colostomy 2%, but others show that loop colostomies can have a prolapse of almost 42%. If you look at the site, maximum with transverse colon and sigmoid colon. I told you, you select the distal part of the sigmoid colon, it's going to prolapse. Why? So basically loose. The predisposing factors, intestinal redundancy. Whatever is lying loose has a tendency to come out. So if it is redundant, it has to come out. If you're not fixed the mesentery, it is going to come. Lack of mesentery fixation, intestinal redundancy, both would be leading to a increased chance of prolapsing. Loops prolapse more than end. And what is peculiar is that whenever loop prolapses, remember, it's the distal limb, never the proximal functioning limb. Your logic would say that because perisplantic is acting on the proximal, I got the distal. Because perisplantic is acting on the proximal, it should come out. No, it doesn't. It doesn't. This distal limb, which is the mucous fistula, that has a tendency to come out. Why? Because remember, with disuse, what has happened in this? It has shrunk. It has shrunk and it is contracted. So now it has become a loose fit inside the facial aperture. Now, because that is a loose fit, so the distal limb always tries to prolapse. So remember, distal limb prolapses more than the proximal functioning limb. Remember that. Okay. Old age, obesity, when created for bowel obstruction in emergency situation, the intraperitoneal, there is increased chance of prolapse as compared to a extraperitoneal. Okay, or what we just now talked about, and a large facial aperture, more than two fingerprints. So the types are two. Number one, fixed, and number two, sliding. The patient give you a history, this keeps coming out, and suddenly when the patient sleeps in the night, it goes back. So that is a sliding variety. The other, the patient comes to the OPD, says, look, this was coming in and out, now it has permanently collapsed, it's not going inside. So that is basically a fixed or permanently collapsed. The sliding inner protrusion basically usually follows the increase or variations in the internal pressure. The patient coughs, comes out. The patient relaxes, goes back in. So the alteration of internal pressure creates the sliding type, becomes permanently collapsed when it starts having adhesion. Symptoms are simple. You can see the bulge, very, very clearly seen, the whole thing with the mucosa. There may be pain. The appliance no longer fits. Very common. You see in the OPD. The patient says, look, this is the bag, I have to bring it. You ask him, why do you remove the bag? He says, no, it's not fitting inside the bag. So poor appliance fit. It can undergo obstruction. It could be incarcerated, no longer going back inside, strangulated. So all these are symptoms which could be there for a prolapse. The treatment could either be simple, just resect the prolapse segment, or convert the loop into an end. You understand the loop is now prolapsing, let me convert it to an end. Or revise after closing the existing ostomy. Do a laparotomy. Or do an ostomy mobilization, bring everything out, you close it and bring a fresh part. So it can either be done per abdominally, or it can be done with a laparotomy. Now conservatively, suppose it has been, the patient comes to you after 2-3 days, that look, this is out in the last 2 days, and what do you find? Huge amount of edema. You try to push it back, it's not going in. A very simple maneuver is, you put a lot of sugar on it, a wet gauze, and just leave for 10 minutes. The edema disappears and you can push everything back in. A very, very good method of decreasing the edema of the prolapse segment, right? Number two, resect the prolapse if it was an ostomy, no problem. Mobilize, bring it out, cut, and then push it back in. Or do a laparotomy, whatever. A revision, if the distal limb is there, what you can do is, you draw the distal limb, close it, and then push it back either extraperitoneally, or tag it to the subcutaneous tissue, or mature it as a fistula, whatever you want, whichever one you want, right? So you can just close that and push it back in extraperitoneally, which would be a very good method, and close the skin around it. So now you just have one hole, okay? The other limb is closed. Or you can do a relocation, which is basically done by closing the existing one, either perabdominally or inside the abdomen, and you can re-establish, continue at that particular point, and make a fresh stoma. But then even that is subjected to a increased risk of parastomal hernia. Peristomal skin irritation, this basically found almost 3 to 42% of patients, presents as number one, mild dermatitis, full thickness skin necrosis can be seen, or even frank ulcers can be seen. We see a lot of patients with that. Everything is red, and sometimes they come with ulcers. So they all present with varying presentations. What are the causes? Number one, it could be a chemical dermatitis. What the immediate thing comes to mind is this effluent. This is ileostomy. The effluent coming out is highly toxic, in the sense chemically irritant, and is going to damage the skin. So chemical dermatitis. Now you would expect that, let me change it more frequently. Don't do it. Don't do it. Do not change the appliance more often than within 3 to 7 days. The moment you try, the more frequent you do it, the more the skin desquamation. It's just like doing a repeating dressing in a dry wound. Patient has dry wound, he asked, when should I get the dressing changed? He said, every day, get it done. Is the wound going to heal? Never. Why? Because the fresh epithelium which comes on the wound, with each dressing, it takes the epithelium off. That wound is not going to heal it. Similarly, out here, when you remove the pouch every day, the skin gets desquamated more and more, right? And this, as said earlier, chemical dermatitis is very common ileostomies, low in a colostomy, right? So what can you do? You can prevent by having a very fitting pouch, which does not allow any effluent to come in contact with the skin. And how can you do that? The diameter of the pouch, that means the nipple that you have made, should be equal to the diameter of the pouch. If you can do that, the leakage around the part of the bowel which has been drawn out would not be there. Why? Because exactly fitting the diameter of the pouch of the pouch, diameter of the pouch. So the pouch equal to pouch would be a simple method by decreasing or preventing the chemical dermatitis. And remember that the part of the bowel which is the functioning, it should be at least 2 to 3 centimeters above the skin level in ileostomies and minimum 1 centimeter in colostomies. Never forget that. It should never be flush with the skin. If it is flush with skin, you can never prevent a chemical dermatitis. Never. The second reason, is that the only reason? No, we don't know what other reasons. You should know what other reasons. Number one is Candida albicans, raised rashes. These are slightly raised surface, as opposed to chemical dermatitis where it is just a erythema or redneck, right? Now, raised rashes, edges with well circumscribed papules and pustules or satellite lesions. You can see all of them in a candidiasis, right? What is required? Nothing but local antifungal application, miconazole nitrate 2% powder that cures this problem. No problem with Candida albicans. The fourth reason or the third reason, a contact dermatitis. Contact to what? The pouch material. The pouch material is lying out there. See this? Very exactly demarcated. Resembling what? The pouch. So this is a sine qua non that this is basically a contact dermatitis. You compare this with the pouch coming from our skin, it will exactly resemble that product. Area by area, point by point. So basically exactly matches the shape of the plant's contact site. There's allergy to the stoma product. What are we being used? Burning, pain, itching, erythema, blistering, and in fact full thickness skin breakdown can be seen. Right? But what is the most notorious is probably pyoderma gangrenosum. Pyoderma gangrenosum, remember, is these all four things are very important. Rare, idiopathic, inflammatory, and ulcerative. All four things, not only here. Pyoderma gangrenosum can occur in any part of the body. It's not only this part. So this is basically a complication. This could be a complication even of an ostomy. So it's a rare, idiopathic, it is inflammatory and ulcerative. It gives a lot of, can you see the ulcer out here? So this is ulcerative, right? That is basically what pyoderma gangrenosum is all about. Often seen with coincident or coexisting Crohn's and ulcerative colitis. This patient has a Crohn's ulcerative colitis for which this ostomy has been made. So that means pre-existing Crohn's is there, ulcerative is there. This patient will be increasingly liable for pyoderma gangrenosum, right? When can it develop? Any time from 2 weeks to 25 years. See this figure? Years. It's not wrongly typed. It is correct figure. 25 years. Can occur anytime. So in end ileostomies, you can have a pyoderma gangrenosum even 25 years after the ostomy has been made. And how does it begin? It begins as a erythematous pustule, papule. They coalesce together. So you have a number of them coalescing together. Will lead to what? Superficial ulcers. You see this induration erythema all around the ulcer. And you'll find the undermined edges out. Right? So all these are features typical of a pyoderma gangrenosum. How do you make a diagnosis? Most commonly by clinical appearances or by process of exclusion. You rule out the other reasons. So basically, that's by process of exclusion. Other thing, does anything help you? No, it doesn't. Why? Because culture sensitivity always negative. Why? I said earlier, idiopathic. No bacteria is identified. If it is identified, it is a secondary commensal out there. Does the biopsy help you? It doesn't. Non-specific inflammation is the report. So nothing helps you. Basically tells you that's an idiopathic inflammation. And how do you treat it? You have to excise, debride, and the wound that is created, do not suture it. See this induration? Don't try to. You can't excise like this. You can't excise this one. So just excise the margins, convert it into a fresh wound, and With the help, you do a wound care, whatever you want, use antibiotic for secondary infection, for the secondary infection, and you use basically cream. But what helps you is a local steroidal cream. Local steroidal cream helps in some healing. And intralesional. In this area, you can inject steroid. Systemically, see these drugs. 6-mercaptopurine, steroid, dapsone, antibiotics, cyclosporin, infliximab, azathioprine. What are these drugs? These are all basically drugs which are trying to decrease your immunity. This is a monoclonal antibody, infliximab. So basically trying to use these drugs to cure a condition about which we hardly know anything. Can we do a relocation? Let's close this, heal everything and then put a fresh paste. No, don't do it. It can recur even at a fresh site. The stricture, stenosis, stomal retraction, I won't be taking too much of your time, just a short part as the complication is concerned. So stricture stenosis, they can occur at 2 levels. One where you attach to the skin, or number 2 at the site where you attach it to the fascia. So facial aperture, and number 2 at the skin aperture. Incidence anywhere from 1 to 10%. Causes could be number 1, surgically small aperture has been constructed, so that creates a stricture, very easy to understand. And that is presenting early with all features of varying degrees of obstruction. But initially there was no obstruction. Later now the patient comes with a late manifestation of some kind of obstruction. And you try to put a finger inside, you put something inside, you find it cannot go in. So there has been stricture stenosis in a late manifestation. Why has it occurred? Either because of ischemia, which gradually led to stricture formation, or infection, which gradually led to stricture formation. Or there could be recurrence of the original disease for which the stoma was made, whether it's Crohn's or there's the recurrence of malignancy, whatever. So basically, it could either be recurrence of the underlying disease, you can't do anything about it, after treating it, or it could be a mechanical problem in the form of either small aperture or ischemia or infection, right? So varying degrees of obstruction is basically the presentation. Treatment, you can do a dilatation, but rarely helps. They actually aggravate, because every time you dilate it, you're creating new wounds and increased fibrosis. So dilatation, remember, always increases the fibrosis. Okay, so don't do a dilatation. What can you do? A stoma revision with or without laparotomy. Either you can do it parabdominally at the site of ostomy, you can do a cutting and you can do it, or you can do a laparotomy and do it. Stomal retractions, again, very important problem. You construct a very good stoma site. You're doing a night emergency, you construct it. In the morning, what do you find? It's not being seen. You just see a hole out there. What has happened? The mobilization was not very good. It was not very good. So immediate presentation is because of improper or difficult mobilization. You had dragged everything to the wall, and then everything went back in because there is no drag force now. So it goes in. What is the drag force now? The mesentery is pulling everything in. So improper and difficult mobilization is the most common cause for stomal retraction. Later, if it occurs later, this is immediate presentation. Next morning, 2 days, 3 days later. But if it occurs further down the line, malnourishment, obesity, immunosuppressed, ischemia, terminal bowel, and stomal site, traction of the mesentery, they can give rise to later presentation. The frequency is not very common, 1 to 6% of colostomies, but more common in ileostomies, about 3 to 17%. Right? Stomal retraction in the early stage could even to the extent that the thing that you pulled out now breaks through these stitches and goes into the peritoneum. What happens? Peritonitis. All the stitches cut through. The seromuscular, the peritoneal, and the skin, the traction by the mesentery was so much that it dragged the whole bowel inside, leading to what? Peritonitis. In those patients where it occurs later, it will give rise to what? A later obstruction presentation. How does it present? The patient now has a difficult pouching and leakage. Apart from this, a difficult pouching and leakage in that particular. Why? Because nothing is now there. It is just flush with the skin. So whatever you try to apply the pouch or the pouching you do, it is going to leak out. So either presentation with peritonitis, obstruction, or difficult pouching and leakage are all presentations of a stomal retraction. Early or late. How do you prevent it? Again, proper and adequate mobilization. We already talked about that. This is one of the most important things. Remember, if you're trying to draw it out and you find any tension of the mesentery, do not continue until you have adequately mobilized the mesentery. So treatment could either be emergency laparotomy required. If the patient has got peritonitis, you have emergency laparotomy, or you have to do a local revision or revision laparotomy if it is a late presentation. either locally you can revise it, but more often than not, you have to revise it by laparoscopy. So what is the choice of segment of bowel and type of ostomy? Temporary fecal diversion, loop ileostomy better than loop colostomy. Already talked about that. Higher prolapse rate and complication rate. Permanent stomas, end stomas are better than loop stomas. Leaving aside the complication, they're all there in every. Even loop ileostomy has a complication. End stoma has a complication. But if you look comparatively, ileostomies have a higher leakage rate, colostomies have a higher hernia rate, right? Just one or two more complications. Stoma ischemia. You've seen that you do a construction and the morning or 2 days later you find the edges blackening off. What does that happen? There's ischemia of that part. So this basically occurring when the thick abdominal wall is there or a small stoma defect is there related to the bowel caliber, which is causing a compromise at the local site. Or there could be a mesenteric vascular compromise. The mesentery is having a compromised vascularity. Why? Because they excessively dissected it or the excessive tension of the mesentery. Ultimately, what is happening? Whatever is happening is ischemia at the particular part, leading to a localized gangrenous presentation in the form of blackening of the edges. Right? The bowel wall may not be demonstrating obvious ischemia in the immediate phase until several days after operation, in those instances where there is gradual mesenteric compromise or the defect is small, not small enough to cause a complete blockage of the vessel, but small enough to decrease the blood flow. Right? Similar to the case of stoma retraction, the importance is whether the pathology is lying at the skin side or it's lying in the facial side. Right? If the ischemia only involves above the fascia, that basically means in the skin side, you do not require reoperation. Excess the mucosa will fluff off, that the ischemia mucosa fluffs off. You don't require to do anything except proper dressing and the pouching. But if it is extending below the fascia, then you have to go in for operative intervention. At that time, either you can go per stomally, that means per abdominally, or you can do a laparoscopy. Okay. Now, per stomally, if you're going per stomally, you have to increase the size of facial aperture, bring up a heavier segment of bowel. That may be successful with one strong question mark. And that is the moment you increase the size of aperture, it may be large enough to give rise to a post-operative PSH, vascularity. So you have to be very careful about that. Right? Now, laparotomy will be necessary if mobilization is not possible per stomally. Right? You have to go in for laparotomy. And often with the mesentery, I told you, you may have to require a loop and stoma. Remember, in any case where there is mesenteric tension, despite the fact that everything, do a loop and stoma, right? That is basically required. And mucocutaneous separation is a condition where basically you find that the stomal edge, rather the bowel edge, has separated from the stoma margin. So you've got a gap in between. A gap in between. Why? Because the wound has not healed. Wound has not healed. Which wound are we talking about? The margin of the bowel and the stomal side on the skin, right? So it occurs as a result of poor wound healing. And the crevice that is formed at separation, that is basically a deep crevice which basically challenges the pouching. Why? Because whatever is coming out always keeps that crevice filled up. Keeps it filled up. So it's never emptying into the pouch. And that is why that would prevent the formation of adequate seal, and it will also be problematic in the sense that it's going to prolong the infection. So if you want to manage this complication, you have to keep the peristomal skin in good condition, optimize nutrition and local wound care to fill in the trough. That basically crevice has to be filled up, right, with ointment or whatever you want, and induce granulation of the wound. Until you do that, this wound is not going to heal, right? So stomal obstruction is the last one, and here you have obstruction from within or without. You see these patients coming back to you, the patient got distended abdomen, the stoma is there, it's not functioning, nothing is coming out. There's a very common complaint. Why? Either the block is from within, inside the lumen, there may be hard feculate, or the aperture has now gradually become tighter. Why? Because the bowel is distending. So tight facial opening of fecal is most common, or from without, something else has happened out there. Either there has been adhesions between the bowel loop, there has been volvulus, or there has been interception. Whatever the reason. So any cause of internal obstruction could be working inside the abdomen. So how do you proceed with this? Do a gentle luminal fingering, right? And give this patient an ostomy enema. That means push a gentle enema inside the ostomy. If there's a hard feculate, it will come out. A gentle luminal fingering, you can identify the feculate. So that often responds. If it doesn't respond, Now you're going for diagnostics for this patient. So give a water-soluble proximal live enterogram or fistulogram. Inject something inside the water-soluble contrast into that. You can visualize until which part the contrast is going. Now you know the obstruction lying there, right? That's one. Number two, you diagnose obstruction by doing a plain X-ray. You see multiple fluid levels. But for diagnosing the exact site, either water-soluble or a CT scan is going to help you, because the water-soluble only telling about the limb, which is basically the part up to which the obstruction is there. What is causing the obstruction, we don't know. We know the block is at this site A, but what is lying behind it, we don't know. For that, a CT scan has to be carried out, and you have to treat the problem accordingly, right? Now, closure principles, you have done ostomy, very happy. Now you have to close it. The patient comes back to you. Look, I have been having this for the last 1 month or 2 months or 3 months or 4 months or 6 months, whatever. Close it now. When do you close it? The closure time is largely determined by the index disease, whatever the patient was suffering from, for which the colostomy has been made or the ileostomy has been made. Now, there are instances where you may have to wait for longer time than 3 to 6 weeks. If other things are normal, optimal recovery conditions, you can attempt it any time after 3 weeks, preferably after 6 weeks. That gives enough time for basically the calming of the abdomen, right? The inflammation subsides. But if the patient had a recovering tuberculosis, a recovering septic abdomen, Crohn's disease, plastic abdomen, these are instances where you should not go in for a selection of random closure even after 3 weeks. Wait. And these are until you are sure that the optimal recovery conditions have been achieved. So the wait normally 3 to 6 weeks, but you may have to wait longer in certain instances, right? Now, if you're doing a small bowel or you have a small bowel ostomy, remember it is always closure with laparotomy, adductolysis, and closure. Remember that. Small bowel, always laparotomy, adductolysis, and closure. Small bowel, the large bowel, you got two options. Either you can do extraperitoneal closure, where you mobilize from the skin side. You mobilize the whole bowel up to the fascia, then go behind the fascia up to the peritoneum. Don't dissect the peritoneum. So the bowel is still attached to peritoneum and free of its moving from where? The fascia, the subcutaneous tissue, and the skin. That means now you can push the bowel after closing into a space which would be the extraperitoneum. So that is an extraperitoneal closure. Why? The mobilization up to the peritoneum, close and push it back in front of the peritoneum, which is the extraperitoneal tissue. So that is extraperitoneal closure. The advantage is only one, and that is if leak is going to occur, then it is not going to contaminate the peritoneum. It is going to burst out through the skin, sutures that you apply. But laparotomy with mobilization would be a better option, where you do a adductolysis and do a closure. Now, your question could be very easily, why can't I do extraperitoneal small bowel? Doing an extraperitoneal small bowel basically will be creating what? You'll be creating a adhesion between a permanent adhesion between the small bowel and the peritoneum. Now that would form like a fixed point, and these two, the ascending and descending limb, are basically free limbs, so you can easily undergo rotation. That is basically volvulus. It's very common. So never do extraperitoneal closure in a small bowel. It has to be dissection and mobilization beyond the peritoneum, intra-abdominal. In a patient having transverse colon or a descending colon, they are not rotating around their axis. They are not. In small bowel, now you're forming an axis for rotation. In the large bowel, it's not there. So remember, in a large bowel, extraperitoneal or intraperitoneal closure. In a small bowel, always intraperitoneal. Right? So thank you. This will continue as part 2 tomorrow. I'll be sending the link. I already created a link, and I'll be sending it to you just now within half an hour. And this is basically the part 2 of this lecture. We'll be talking about the or the enterocutaneous fistulas and the enteroatmospheric fistulas. And I think I've loaded 2 or 3 lectures which I've already taken in the past during this time of the COVID. And they're all there for you to see either through my website. You can go to the website and you can go from there, or go to YouTube Prime site, YouTube Prime, and there just tag in Rajiv Sinha and you'll find the videos and the lectures out there. I think that would be all. Thank you for your time.